You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. I'd like to thank you all so much for joining us on this episode. Today, we're going to be discussing bispecific antibody therapy, including administration and current indications, strategies for patient selection and monitoring for side effects, as well as emerging trends. I'm delighted to be joined by Dr. Celeste Bello, who is a senior member in the Department of Malignant Hematology at the Moffitt Cancer Center in Tampa. Celeste, thanks for joining us.
Oh, thanks for having me, Ken. I appreciate it. I always like everything LLS does for our patients and our community, so I'm more than happy to help.
Thank you, and I totally agree with you. You know, I want to start out, I'm a generalist, and so I've been using monospecific antibodies, Rituxan. I've been using cetuximab. I've been using Avastin, other antibodies like that. And you know, in a sense, there's the second level of antibodies I've been using, brentuximab vedotin, and others like that. I'd love for you to give us a little bit of a review in terms of monospecific, bispecific, and also your predictions where we're going.
Yeah, sure. The monospecifics or the monoclonal antibodies are the older ones, and everyone is familiar with rituximab, which is probably the one we use by far the most in lymphomas. And the thing with those is kind of like the name implies, monospecific. It's an antibody, kind of the typical one you remember from medical school, the little Y-shaped, and it binds to one receptor, and that's it. And so with Rituxan, it binds to CD20 and elicits its effects through the binding of CD20, either causing apoptosis of the cell or activating the humoral immune system or complement-mediated immune system too. So that's how they work. But then, as you had alluded to, now we have newer versions of these antibodies, and brentuximab vedotin is also a mono antibody. It only binds to one site, but it's an antibody drug conjugate. So it doesn't really work through immune mechanisms. I always think of it as like a Trojan horse, where it's an antibody that has a poison attached to it. When it binds to the antigen on the cell surface, CD30 for brentuximab, it gets internalized and the poison gets taken in. And that's what does all the dirty work there. But now you have these bispecifics, and this is a whole artificial form of antibody where they, instead of having just the one Y arm, it has two arms and can bind to two different antigens. And basically, one arm is to bind to the antigen on the lymphoma cell. So in lymphomas, the bispecifics that we have available are CD20 bispecifics. So they would bind to CD20. And then the other arm binds to CD3 on T cells. So basically, it's kind of like a T cell engager antibodies. I always think of it as it's grabbing one and grabbing the other and bringing them together to fight.
Yeah. Let me ask you, in our patients' bodies, what really prevents that from happening, just naturally? What are some of the mechanisms by which cancer escapes that process?
No, that's a really good question. I think a lot of it we don't know, but in the case of avoiding your T cell or your T cell surveillance system, a lot of times some of these lymphomas have receptors on them that block the T cells from engaging the tumor cell. And so one way to do that is to just artificially grab the T cell and activate it by binding to the CD3 receptor. But yeah, a lot of these cancers in general, but in particular lymphoma, have receptors that block the T cells from engaging them.
Terrific. If you would say a little bit more about the process. So you've got a bispecific antibody, it binds to the malignant cell. What happens next?
So basically, it's mimicking an infection. It's mimicking the T cell's response to an infection, but it's artificially doing this. So you have your bispecific, binds to the, let's say, CD20 on the lymphoma, binds to the CD3. on the T cell. Now it activates the T cell, and now the T cell releases cytokines, other proteins that basically punch holes in the lymphoma cells and cause them to die. So that's pretty much how it's done. I know when I'm talking to my patients, a lot of times I tell them, we're going to mimic sepsis, basically, but we're going to try to control this so it kills the lymphoma, but not you.
What are the indications for bispecific antibody therapy now?
What I was going to kind of focus more would be on the bispecifics for the B cell non Hodgkin's lymphomas, follicular lymphoma, and diffuse large B cell. So the indications in all of these are for two or more lines, patients that have progressed after two or more lines of therapy. So the big three that we have now, bispecific wise for lymphomas, are mosunetuzumab, glofitamab, and epcoritamab. So the mosunetuzumab is for follicular lymphoma, and it only has the indication for follicular lymphoma at this moment. And it's for patients that have progressed despite two or more lines of treatment. The other two, glofitamab and epcoritamab, they have indications for diffuse large B cell lymphoma. And again, same thing, people who have progressed despite two or more lines of treatment. Recently, epcoritamab also got FDA approval for follicular. So epcoritamab is the one CD20 bispecific that actually has indications for both follicular and diffuse large B cell.
So, Les, let me ask you from your clinic experience in the last 2, 3, 4 weeks, can you give an example of a patient who's been through treatment, let's say for follicular lymphoma, where you would start to think about a bispecific antibody therapy?
The one patient I'm thinking of right now, she had been on multiple treatments, including CAR T cell therapy. So she had undergone CAR T and had really aggressive, transformed large B cell from a follicular lymphoma and with bone involvement, everything. And really, probably about 2 or 3 months after the CAR T, she just had progression again. So we had kind of exhausted pretty much all options. And so he said, the CAR T therapy is targeted more for CD19 for non-Hodgkin's lymphomas. So he said, well, why don't we, try one of the bispecifics because it's targeted for CD20 and it's almost like a off-the-shelf CAR T because it's engaging T cells still. So we tried her on it, and I mean, within 2 cycles, she went into a complete remission.
Wow, how wonderful.
Yeah, I mean, she actually finished because she's on glofitamab, and glofitamab we usually will do for 1 year. So it's usually limited for 13 cycles. And she just finished her 13th cycle and is still in remission. So it was really phenomenal because it didn't really have much else to offer this lady. So it was nice to see this work in her situation.
Such an interesting case presentation. At some point, you'll stop the therapy. Again, as a generalist, when I'm giving patients checkpoint inhibitors, I sort of talk about the possibility of the immune system being educated to fight their cancer. With this situation, using a bispecific, if there's ongoing benefit for her, what will be the mechanism of it? Is there some education of the immune system? Or what do you think?
Yeah, I don't think that happens, unfortunately. I think these antibodies, they have a limited lifespan.
Yes.
It's always hard to know the half-life of antibodies, and so they're kind of unpredictable. Once they're out of the system, that effect is no longer working.
Yeah, got it.
I don't believe there's any kind of learning or, unfortunately, what would be the word, like a persistent T cell.
Valence of some kind.
Yeah, maybe in the future we'll find out this is wrong, what I'm saying, but I think it's more that they're being cured,
Yeah,
that
yeah,
we're
yeah.
killing them off and now the lymphoma's gone and that's it. Or at least that's what I'm hoping is happening.
No, absolutely. And thankful for all of this. But there are patients who have prolonged remissions and, God willing, cures where we didn't necessarily expect it.
Yeah, definitely. So those are always good surprises.
Yeah. You mentioned it's different than B cell, it's T cell and about lysozymes. Are there other forces at work in terms of using bispecific antibodies? Are there any other changes in the microenvironment or, again, the immune environment?
Well, I think that's also a really good question because I hope there is some attacking of the microenvironment too. Some of these lymphomas, they do rely a lot on the microenvironment. So if we get some of those T cells, like they use the microenvironment to shut the T cells down a lot of times. And so it's kind of more, I think, that this is helping turn those T cells on
Got it.
and avoid that process. So I think that's a good point that you bring up, that not all of the immune avoidance of the immune system from these lymphomas is from cell antigens or receptors on the cells. Some of them are from the cells they attract in the microenvironment that kind of turn off the T cells. So I think that's a good point.
A question that may be unfair from the point of view that is obviously going to vary per patient. So let's say you have a patient with a large cell lymphoma and you've treated them. And I have to say, when I go into this, my hope and my expectation is, oh, they're going to be cured. Well, obviously that doesn't always happen. So how do you make the decision about what to do next? A bispecific, CAR T, allogeneic transplant, autologous? What goes into your thinking?
Yeah. I mean, fortunately, we have a lot of options now, which is
Yes,
great.
yes.
So I don't really think there's a complete wrong or right answer here. But basically, what I think of, if it's a diffuse large B cell and they're relapsing after their first line of treatment or their primary refractory, and the patient is, I'm not going to say fit, but that the patient's in fairly good health and good performance status, I usually will send them to CAR T now in first relapse. If it's been a little while, like let's say a year or more, and now their lymphomas coming back, I usually will still do the traditional salvage chemotherapy and then autologous stem cell transplant. Only because I feel like if they're coming back and it's been a while, they did get a benefit to chemotherapy. If they're primary refractory or they relapse within like 6 months, you kind of think, well, doing more chemotherapy is probably just, spinning your tires. And so that's kind of how I look at it. And then for the bispecifics, we usually use those if they progress after CAR T, or if it's somebody who is maybe not in a situation that they can get CAR T therapy. For example, sometimes they're progressing so quickly, it takes weeks to collect the T cells and then engineer them. Sometimes you don't have that time, and so that's another option where you can go to the bispecific instead of CAR T treatment.
Again, there's a group of patients who are cured, they do well, let's say with large cell. We see them for 1 and 2 and 5 and 10-year follow-ups, all as well. But there is a group who eventually relapse. And it's not a small group, it's a relevant group. Some of the therapies, CAR T has a fair amount of toxicity, allogeneic or autologous, they do too. Could you see a role for the bispecifics as a consolidation?
They're not completely benign, the bispecifics. So I don't think so much for consolidation if the patient's already in a complete remission. But definitely, I think in the relapse setting, I think there's a lot of potential for them. I also think probably in the frontline setting, adding them to chemotherapy regimens
Yes,
probably
yes,
going to be really the future of
yes,
this, because everything always works better the earlier you give it. So it's kind of like,
true.
might be the way to go.
Along those lines, look at Hodgkin's disease now, where again, we're using brentuximab vedotin. Again, could you see that happening, let's say, with large cell or with follicular?
I do. I really do see that happening. I think even more so in follicular because we don't really get cures with
Mhm.
chemotherapy and low grade follicular lymphomas. But you kind of see possibly some cures with bispecifics because you do see the survival curves. In some cases, especially people in complete remissions, will plateau, and 3 years out, 33 months out or so, they're still in remission. So the problem obviously with follicular lymphoma is you have to follow these people for 10 or 20 years before you can
Right.
say they're cured.
It's a
But
career.
yeah, right, right. So these studies probably are not going to do that.
Right.
But I think to me, that sounds phenomenal to give somebody that up front and avoid chemotherapy pretty much altogether and put them in an indefinite remission and see how long you can do that.
So let's tell us some about pre-meds and preparing patients for this type of therapy.
I guess kind of more of a like a housekeeping or administration of the drugs, just to point out the differences. Since I get asked this a lot about, because they're like, well, which one do you use? They're all three the same. And it's like, well, they're not quite all three the same, but they all have good results in CD20 positive B cell lymphomas. But I will say, for instance, glofitamab and mosunetuzumab are intravenous, whereas epcoritamab is a subcutaneous injection. So that kind of brings up, hey, if there's somebody that's having issues with IV access, you might want to use epcoritamab instead. Glofitamab, usually we use a small dose of monoclonal CD20, obinutuzumab, before we give the first dose of glofitamab. Then you give the glofitamab usually 7 to 8 days after that. Whereas the other two, mosunetuzumab and epcoritamab, they don't use any pre anti CD20 treatment. And all three of them, it is recommended to pre medicate with acetaminophen, antihistamine, and steroids. So there's a little variability with that, and more so to do just with administration and toxicity management.
I want to dive a little bit deeper on side effects because, again, many of us in the community have been involved with bispecifics marginally. So, what is there to expect, again, when you treat a patient with a bispecific? What are you looking for?
Yeah, definitely a very unique cluster of side effects here. All of them are linked to immune activation. I usually will tell the fellows in training and the residents here just anything you think is related to SIRS or sepsis. And if somebody's on a bispecific, let's assume it's a bispecific. So the main things we look for are like cytokine release syndrome. So the cytokine release syndrome, basically these patients will get fevers, hypotension, sometimes they get some hypoxia, altered mentation can happen. That usually gets a different name. They call that ICANS, or it stands for immune effector cell acute neurotoxicity. I think I finally got the anagram right.
Well,
So the neurotoxicity, I mean, sometimes you'll see people get pretty encephalopathic. So those are all things to look for. But the good news with these bispecifics, it seems to be a lot less severe than what we see, because we see the same issues with CAR T cell therapy and other immune therapies. But the bispecifics, it's a lot lower incidence and severity.
so again, perhaps a difficult question, maybe not, but who should be giving a bispecific? Should the generalist oncologist, of which there's a lot still, practice in the community? Should it only be at a tertiary center? What are your thoughts on that?
I think it kind of depends on which bispecific, because there's actually some variability between the different ones. So, for instance, the glofitamab one, it definitely has a little bit more severe cytokine release syndrome. So, in that case, we usually admit the patients to the hospital for the first one or two doses of it. The other ones, like the mosunetuzumab and the epcoritamab, they still have the CRS potential, but it's a little milder. And we usually don't admit those people. We usually just have them come in and get it in the infusion center, and then usually have them kind of stay for a few hours and then have instruct their caregiver what to look for. So I really think there's potential, those two, the mosunetuzumab and the epcoritamab, to be used in the community. It's just a matter, I think, of people just getting more familiar with the side effects and how to manage them. It's a whole new class of drugs, so there's a little bit of a learning curve.
So there's a group of patients who are mobile and motivated and can get to Moffitt and other tertiary centers. There's other patients who really can't. What kind of partnerships can you see between academic centers and community practices in caring for patients who need bispecifics?
Yeah, I think one of the things I kind of foresee happening, or a way that we can kind of work together here, most of these side effects, like the cytokine release syndrome, happen with the first cycle. And then after that, the patients are kind of like on cruise control. And even the regimen gets easier, because most of them give the infusions in a step up dose fashion the first cycle. And then the second cycle, they usually will go to the set rate. And then it'll be depending on which one you're using, every 3 weeks or every 2 weeks. And so I think probably what would be maybe a way to help kind of be in the middle here is to do the first cycle in maybe an academic center. So then you get them ramped up to the tolerated cycle, where it goes a lot smoother, a lot lower incidence of cytokine release. And then the odds of any serious reactions or side effects, it really drops off after the first cycle.
Got it. I mean, something like that actually feels very comfortable, I think, for myself as a practitioner, and I think for patients too. And then when we're all benefiting, honestly, from the expertise of clinicians like yourself. With CAR T, there's been talk about sort of the issues with manufacturing and supply chain and how long it takes a certain amount of time. But tell us a little bit more about those same issues with bispecifics.
Yeah, the bispecifics, they're pretty much ready to go. So, unless there's a break in the production of the drug, I mean, they're on the shelf and they're ready. If you admit somebody, they can get it that same day for the first cycle dose or in the infusion center. Probably the biggest barrier is getting the insurance authorization. The drug is ready, it's there.
Yeah. Let me ask you about that. Any studies that you're aware of that have looked at cost effectiveness of bispecifics?
Yeah, I'm not aware of any at the moment. I think they're kind of new right now. So I think everybody's still getting kind of their feet wet as far as administering them and getting them more out there. And I just think it's phenomenal how fast they hit the market and became like, oh, let's use them every day. And it just went from like, yes, it's like I woke up and all of a sudden there were 3 bispecifics available to use.
Right, right.
So I think everybody's still in that phase. I think when they start to be moved more towards first or second line, the cost effectiveness is going to become more of an issue. Because when it's like
Absolutely.
third or fourth line, at that point, you don't really have good options. So it's kind of like money is no object.
Yeah, I think you summarized it really well. Yeah, it did happen. It happened actually a lot faster than I've seen with other classes of drugs. So it is going to take some getting used to. And finally, let me just ask you about meetings on lymphoma. What are some of the things that we can look forward to? What are some of the clinical trials? And just your own predictions where you think this field will go.
Yeah, well, there's actually several out there now for frontline combining glofitamab with CHOP for large B-cell lymphoma, epcoritamab with CHOP for large B-cell lymphoma. I've seen several just listed. If you go to clinicaltrials.gov, there's at least 10 listed on there. So I feel like they're going to be moved more to the frontline setting. I don't know if it would take the place of Rituxan since it's another CD20, or if it'd be in addition to Rituxan. That's kind of where I see this moving is towards the front line. I think one thing to put the brakes on this is that we do need to figure out or have more data on the long-term toxicities because as we've all kind of started to see with some of the checkpoint inhibitors and even with CAR T, there's a few little studies now coming up about secondary malignancies or secondary consequences related to this immune alteration. So
Yes,
I think
yes.
important before we jump on the bandwagon that we do maybe get a little more long-term data because we have pretty good treatments already for diffuse large B cells. So dumping CHOP and Rituxan, which has been tried and true for 20 plus years, 25 years, it's kind of, I think, a little premature, but that's where I see it going. I see it going more to the front line.
Yeah, terrific. I was just going to comment. I remember the study because I was a fellow at the time, but it was R-CHOP versus 3 other regimens. It wasn't R-CHOP, it was CHOP versus MBACOD, MACOP-B, and there was a 4th regimen. But your point's well taken. In that case, just plain old CHOP ended up being just as good with less toxicity. So I think obviously having a critical eye toward outcomes and toxicities will be important. Again, this is Dr. Ken Miller. I've said this has been a terrific episode, so interesting, and talking about trying to improve the chance of curing patients with non-Hodgkin's lymphoma. Again, a disease where a lot of progress has been made, but how terrific to see this next level. And with that in mind, I want to thank Dr. Celeste Bello, who is a senior member in the Department of Malignant Hematology at the Moffitt Cancer Center. Celeste, thanks for joining us.
Oh, you're welcome. Thanks again.
And I want to thank all of you for listening to this informative episode. For a listing of all of our healthcare professional continuing education activities, including podcasts and healthcare professional resources, please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families that could be found at lls.org/support. I also want to encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, please click the feedback button on this episode page, and we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.